Good afternoon, and thank you for joining us for the Advancing Medical Dental Integration for Veterans panel discussion. I'm Chelsea Chokas with CareQuest Institute for Oral Health, and I'm pleased to introduce our moderator, Rear Admiral Timothy L. Ricks, who currently serves as the 20th Chief Dental Officer of the U.S. Public Health Service, as well as the Assistant Surgeon General, a 4-year term appointment he has held since September 2018. He serves as the Surgeon General's spokesperson on oral health and interacts with chief dental officers from other countries, military chief dental officers, leaders in organized dentistry and public health, state oral health programs, and much more. Rear Admiral Ricks has served in the U.S. Public Health Service for over 22 years as a clinician, including being named Indian Health Service National Clinical Dentist of the Year and unprecedented 4 times, and an administrator. I'll now turn it over to Rear Admiral Timothy L. Ricks to introduce today's panelists.
Thank you very much. So today's topic is advancing medical dental integration for veterans. So please allow me to introduce our distinguished panelists. First is Dr. Hugh Silk. Dr. Hugh Silk is a professor in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School. He also teaches at the Harvard School of Dental Medicine. He is co-founder of the award-winning national curriculum on oral health for health providers entitled Smiles for Life. He is the past president of the American Association of Public Health Dentistry's past recipient, of the AAPHD Public Service Award as well. When he is not teaching and seeing patients, Hugh is collaborating with CareQuest and Harvard School of Dental Medicine to help develop the Center for Integration for Primary Care and Oral Health. Our second panelist is Sarah Holland. Sarah Holland is the CEO of Virginia Health Catalyst, a public health nonprofit organization ensuring everyone in Virginia has equitable access to comprehensive health care. Her organization led the advocacy efforts that brought a comprehensive dental benefit to all adult Medicaid members last year. And she was recently honored by the National Network of Oral Health Access as the first COVID warrior for recognition of Catalyst's support of dental safety net providers during the pandemic. Our third and final panelist is Dr. Michael Jakes. Dr. Michael Jakes attended the University of Texas School of Dentistry at Houston. Upon completion, he served as a dentist in the United States Army, which included deployment to Baghdad, Iraq, from 2005 to 2006. In 2013, Dr. Jakes switched branches and joined the United States Navy Reserves as a dental officer and continues to serve with the reserves. On the civilian side, Dr. Jakes holds the position of Manager of Clinical Management with CareQuest and oversees dental consultant, staffing, and operational processes. Dr. Jakes volunteers once a week at a federally qualified health center in Round Rock, Texas, which includes providing care to our veterans. So let me start today's panel by talking a little bit about the issue of integration. There was a recent data brief published by the American or Agency for Healthcare Research and Quality, or AHRQ, that showed in 2018 in America, 64.7 million people neither saw a dental provider or a medical provider. There were 112.3 million Americans that saw a medical provider, but not a dental provider. There are 121.2 million that saw both a medical and dental provider, and there were 28.2 million Americans that saw only a dental provider and not a medical provider. So clearly there are opportunities both for medical providers to integrate oral health into their practice environments and opportunities for dental providers to integrate chronic disease screenings and so forth into their practices. So we'll start off with a question from Ms. Holland. Ms. Holland, you have long advocated for patient-centered care models. The report that I just mentioned said that there were 28.2 million Americans that see a dentist but not a medical provider, and 112.3 million that see a medical provider but not a dentist. How would, in your mind, how would a bidirectional, patient-centered, integrated care model look in the future to you in promoting veterans healthcare?
Yeah, well, thank you for that question. And thank you to my colleagues who I'm here with today. And I really appreciate the opportunity to be able to talk about veterans health and total health all the time. So it's really wonderful to be here. I think I would start the answer to that question with oral health is health, and that looks like no wrong door. So wherever a veteran is showing up, a veteran is going to have the ability to receive all of the care that they get, whether that's in a warm handoff referral or in actual care being provided by the individual practitioner. And I think that that no wrong door is especially important when we think about veterans and veterans health. Annalise gave me some pretty startling data when we were prepping for our conversation today about access to coverage for dental and then the utilization of that access. So only about 15% of veterans are eligible for care, but then only 35% of that 15. So I can't do that math off the top of my head, but that's a really, really small number are actually utilizing those services. So we know that the likelihood of an individual or a veteran of having a dental issue is pretty high if they're not receiving any kind of regular dental care. And we also know on the flip side of that, that a veteran is more likely than somebody in the general population to be a diabetic and also more likely to suffer from heart disease. So the opportunity to provide comprehensive healthcare is not only necessary, it's vital to ensure that veterans are able to be totally healthy. And so if that means a veteran is showing up at their dental office because they have dental pain or even for a preventive screening, and the hygienist in that office or a dental assistant in that office or a dentist in that office is making sure that the patient is receiving blood pressure, that they're talking about their diabetes, perhaps testing their sugar levels, communicating with any kind of primary care medical provider that exists for that patient to make sure that that care is continuous, that's going to be really important to the overall health of that veteran and that individual. And I would also add that one more thing I would like to make sure that we don't lose sight of when we're talking about bidirectional care and integration is the social supports that are just as necessary for an individual to be healthy. So certainly we've got to think about referring for primary care or referring for dental care or referring for behavioral health and making sure those handoffs are warm, that they're bidirectional and all the pieces that I know we care about a lot. But we also need to be thinking about screenings for social determinants that go beyond what we may think of as medical and dental, for homelessness, for food insecurity, and for other issues that are absolutely going to affect an individual's ability to be healthy, but may not be able to be addressed directly in a practitioner's office. But I think no wrong door is the best way to sum that up.
Wonderful. Thank you, Ms. Holland. So the next question is for Dr. Jakes. Dr. Jakes, first of all, thank you as a veteran. Thank you for your service to our country. The question is this: after service members retire, they have 1 year to have their dental care taken care of at a VA hospital. But in past presentations, you've mentioned how difficult it can be for veterans to access dental care at VA hospitals. How do you see an integrated delivery model being a way forward to screen veterans in primary care settings and refer them to a dental home?
That's a great question. I mean, being that I was active duty and went over to the reserves, I did have a 4-year gap where when I was being released from active duty, where I voluntarily resigned my commission, which is what you do when you get out. They gave me 1 year, and I'm already a dentist by the time I was leaving, but they give you 1 year to try to take care of your dental care. For me, it's not a problem. I already found a job at a dental office in Houston at the time. And I was lucky to have a very large VA hospital out in Houston too, in the medical center out there. But it is a problem. being from Round Rock, the Austin area, we have a VA hospital, but it's pretty far south of Austin. So the FQHC that I volunteer at over at the Sacred Heart Community Clinic, we see some veterans and they just can't get all the way down to South Austin. So I think one of the biggest challenges for sure is, especially when you first get out and you're looking for a job, or even if you're a long-term veteran, just trying to find access. There are some hurdles, but overall, you know, the VA hospitals are there to help, but there's still a bottleneck effect there too, not only just to get access, but also being able to be seen. And, you know, just to dovetail on what Sarah was saying, you know, the key is integrating every aspect of it, you know, with the medical health aspect, behavioral health, and even the dental health, just to be able to coordinate that within the community, I feel like is extremely important.
Wonderful. Thank you, Dr. Jakes. Next, I want to ask Dr. Hughes Silk a question. And during my introduction, I mentioned that he was part of the Smiles for Life curriculum. So, Dr. Silk, you are a part of the National Interprofessional Initiative on Oral Health, which works closely with the Smiles for Life National Oral Health Curriculum. Can you tell everyone more about that program, the different modules in the curriculum, and how these might be applicable to improving oral health in veterans?
Yeah, thank you. Smiles for Life has been around for about 15 years. It's a proven web-based tool for educating learners and also for educating clinicians. So, I mean, one really important message is there's no need to reinvent the wheel. We don't need to keep creating new and different curricula. This is a curriculum that has been updated 3 times over that 15 years, and will continue to be updated. There's 8 core modules, and those sort of expand across the life cycle. I think for veterans, the most important ones would be, there's one on adult care, on urgent care, on how to do a proper oral exam, the systemic oral relationship, and then there's a prenatal women's and oral health module, and finally a geriatric module. So it really spans all of the issues that would come up. So far, we've had about 3 million users, and the ratings from those users are in the 90+ range in terms of like how well they feel the material was for them. And we even wrote a paper showing that when providers trained with Smiles for Life, they changed their behavior. They actually engaged patients more around oral health. So, we're pretty proud of this. It's been endorsed by medical folks like the Society of Teachers in Family Medicine and the American Academy of Pediatrics, but also by the dental side, American Dental Association, American Dental Hygiene Association. The funding comes from CareQuest and our Cora and the Connecticut Health Foundation. And again, when we look at our user numbers, this has been used both by teachers trying to train learners, but also by providers in the community. So on the learning side, it comes with questions for the modules and cases and that kind of thing, where people can just do the modules on their own. When you think about how does this apply to veterans? So anyone providing medical care, whether you're in the VA or outside the VA, I think Sarah was quoting the dental numbers earlier. It seems like for medical, about 60% are eligible for medical and less than 50% use the VA. So we really want to get to both formal VA providers, but also all those primary care providers and specialists in the community. And a lot of those providers didn't get the training when they were residents and medical students and PA students and NP students. So this is a way to do that. I guess if we back up for a second, though, I think one message I really want to get across today is, even though we're focused on veterans, there are all of those folks who go into the military in the first place. And when we look at the numbers of people entering into the military, the numbers I've seen is about 40% can't be deployed to go off to serve overseas because of dental health issues. So to me, that's a real snapshot of our society, that we've got all of these folks entering the military whose mouths are not ready for service. So even more so, we've got to get the medical side trained to be addressing oral health of young people, kids, teens, etc., so that they're addressing oral health before it becomes an issue, before someone goes into the military. This is a health equity issue. And so if we're reaching out to primary cares, but also to Head Start and school-based programs and federally qualified health centers, and getting folks' mouths in better shape before they enter the military, then they'll be getting that care during the military, and then we won't have as big a need afterwards. But in the meantime, you know, my goal in life and some of the work I do, which I'll speak about as this session goes on, is to keep engaging primary care providers.
Wonderful. Thank you very much, Dr. Seal. Okay, let's engage all the panelists now. So as we know, veterans suffer disproportionately from heart disease, diabetes, mental health problems, and more. And we often talk about multi-directional integration, whereby medical professionals do oral health screenings, fluoride varnish, and refer patients to oral health professionals. But on the other side, we see oral health professionals doing things like chronic disease screenings for things like hypertension, diabetes, et cetera, providing immunizations, especially like during the pandemic, and doing other things that might be traditionally outside of their scope of practice. What do you see as the biggest barriers to having full bidirectional integrated care in the future using the definitions I just gave you? Let's start with Ms. Holland.
Yeah, thank you. So there's a lot of barriers. I mean, I think we could certainly take a deep dive into that as well. And I certainly am someone that likes to lean on the more optimistic side, but I do think that it's important for us to note interoperability and a lot of communication challenges and things like that. I do think at its core, one of the opportunities here is that this is really change management. And particularly if we're thinking about students. And I think that, you know, Dr. Selk's program and a lot of the work that's been done to make sure that as we have new PAs and nurses and physicians coming into the world and joining practices, that they are getting the education that they need at the school level to be able to do fluoride varnish and make referrals and talk to their patients about diabetes and do those things. And then they're often entering practices where that is not the status quo. And so they're coming in as a junior practitioner, having just left school with, you know, some new great skills to provide comprehensive healthcare for their patients and probably some really good ideas. And they're very likely to be met with some resistance to doing that kind of change. And I think that means that folks like us need to be kind of doubling down on some leadership education for the students and some real talk about the fact that, you know, they're learning in a perfect bubble. And when they're going to go out to practice, things are going to look a little bit different. And there's going to be some very natural negotiating that needs to happen as they're operationalizing a lot of the great things that they learned in practice. And I think then on the flip side, practices are going to need to be open to new workflows, to learning new things that they didn't necessarily learn in school. Smiles for Life is a terrific tool for that. And I hope that we say over and over that there is no need, just like Dr. Silk said, to recreate the wheel. We have some awesome education around this for our existing providers. But I think we need to acknowledge for the newer clinicians, it is going to be a little bit about change management and in some cases truth to power. And I think when you're looking at some existing clinics, making sure that they understand that there are some existing workflows that they can adapt and some ways that they can easily meet that challenge. And also for those of us who are advocates to recognize that there's a lot of emotion wrapped up in that is completely separate from wanting to do the right thing for your patients. You know, a clinician feeling uncomfortable because it isn't something that they learned in medical school, or feeling uncomfortable because it's not the way they've been practicing medicine or behavioral health or whatever it is that their specialty is. And I think that it's really important for us to remember that and help provide some tools on all of those points in the continuum to help folks move along.
Great, thank you. So let me ask the same question of you, Dr. Jakes. What are the biggest barriers for future total bidirectional integration of oral health and overall health?
Well, I see it firsthand when we opened up the medical clinic, the Sacred Heart Community Clinic out in Round Rock, about 10 years ago. It was just a medical clinic, and I just so happened to live right by the clinic, and I know some of the people, so they kept asking me to come in and do, extractions, and I couldn't because there was no, dental setup. So I think that's, first of all, that's a pretty important point is, medical, as we're talking medical and dental, behavioral health, it all goes together. And, ultimately we were able to open up a dental clinic and we were able to incorporate, the overall health for everyone. I think one of the challenges that has been discussed for sure is, yes, a dentist can provide vaccines such as COVID vaccinations. How often does that occur? From what I understand, only 3.5% is what's happening as far as dental providers offering vaccinations. Because, truthfully, and Admiral Ricks, you probably know this too. I mean, we don't learn about that in dental school. We learn about doing fillings and learning how to achieve proper anesthesia and make sure the patient's comfortable. But we do not step outside the box. And, it's great to hear these programs that Dr. Silk's, overseeing, to see if we can incorporate that on the medical school side, PA, and then also dental, that we're able to try to become more well-rounded than we have in the past. But yeah, the key is just building that referral network and being able to cross over from one provider to the next and seamlessly do that without any hiccups. I think that would be very important if we could try to continue to do that.
Wonderful. All right. So same question, Dr. Silk. What are the biggest barriers you see for full bi-directional integration of oral health and overall health?
Well, I'm going to try and take a positive approach to this because I agree with someone, like there are a lot of barriers. One of the things that I've been impressed by was you might think it's the providers themselves or patients or what have you, but Michael Glick at UPenn did 3 papers that looked at this, and patient acceptance and medical provider acceptance and dental provider acceptance was actually pretty high for this bi-directional work. And that the patient one is maybe the one we want to look at the most, because they said that they actually would think more highly of their dental provider if they were offering immunizations, if they were working closer with medical folks. So I think if patients are wanting something, I mean, look what's happened in the urgent care world and online and things like that. So I think that's a very positive barrier that has sort of already been lowered. In my life, I would say, the electronic health record is probably the biggest barrier. When I refer someone to a cardiologist, it just happens magically, and it's the next day the person's off to the cardiologist. When I want to refer someone to the dentist, even though I am a champion of this, I mean, I have to walk down the hall and find the list of the dentists we like to use and circle a couple and hand it to the patient. And if they're having troubles, I go out to the front staff and they try and help them make a phone call. Then we fax something over. 19th century stuff. It's like, but for everything else, it just magically happens. So my understanding with Epic and NextGen and these things is a lot of the features are there. We just need to turn them on. And then we need to utilize them and work on workflows. The last thing I'll say about positivity is this idea of being co-located, but like really integrated. And I'm sort of excited when I see the work of people like Patty Braun in Colorado, like in multiple offices, having a dental hygienist right in the office, engaging patients and doing those warm handoffs and getting people some exam and advice there, and then getting them over to the dental clinic. So I think the barriers are coming down. I guess that's my message. And these pilot programs just need to be ramped up.
Great. Okay. So using that positive slant, the next questions for all 3 of you. What additional training do we need to promote the multi-directional or bidirectional integration of oral health and overall health? So specifically, what additional trainings do we need in dental school to promote chronic disease screenings by dental students and oral health professionals? and what additional training do we need in medical and PA and nurse practitioner schools to promote oral health screenings and preventive services by medical professionals. So Dr. Silk, since you kind of raised this issue, let's start with you. How would you answer that?
Yeah, pardon the pun, but I'm kind of chomping at the bit to answer this one because this is what I do. We have this center, as you mentioned at the beginning, the Center for Integration of Primary Care and Oral Health, which we call CIPCO, and it's sort of a cooperative agreement between Harvard and UMass. Was founded with some HRSA money, which we're really grateful for. But one of the projects that's come out of that is called the 100 Million Mouth Campaign, and HRSA helped us get that started. CareQuest is now funding it to keep it going. And what it is this idea that if we could systematically get every medical school, osteopath school, family medicine residency, pediatric residency, et cetera, physician assistants, nurse practitioners, engaging in oral health as learners, then they'll go out into the community and do that. And I think Ms. Holland is right. Like they might, hit some barriers when they first get out, but if they're all graduating with this knowledge, we'd be in a better shape. So we're taking this approach. We started with 6 states. We created Oral Health Education Champion to engage the schools and residencies in their state. We added 8 more states this year, and we want to get to the point where we have 50 state champions, and then just keep like school by school, residency by residency. We train up these education champions. We show them best practices. I've been fortunate at UMass over the last decade to weave oral health into, I guess we're up to 18 of our 26 foundational courses now. So whether you're learning your physical exam and you're learning how to examine the mouth properly, or you're learning how to do fluoride varnish in your pediatric rotation. So this is coming. I wish I had even more money to go quicker, but it is coming. And I think to Ms. Holland's point, in the meantime, we need to be doing some continuing education sort of stuff for those in practice. I'm really, I like American Academy of Pediatrics had a oral health knowledge network, and they recently handed that over to the National Maternal and Child Oral Health Resource Center, which is calling it the Oral Health Learning Cafe. And so it's just this idea that you come together once a month, you talk about oral health topics, you go back and try them out in your office. Rebecca Bernstein, for example, came from Wisconsin. She's a family doctor, and she said, hey, I started a cavity clinic in my office. I'm doing silver diamine fluoride. This is how I got it going. This is the oversight we had from a dentist. We can work together on this. So I guess the combination of like systematic approaches to schools and then just chipping away at those already in practice.
Great. All right, next, Dr. Jakes, same question. What additional training is needed? You mentioned, dental schools and how we don't necessarily learn how to give vaccinations and things like that. So what additional trainings do you think are needed?
Yeah, I mean, it goes on the other side too, medical training, dental training. I mean, if we could incorporate, additional accreditation standards, whether it's from the current educational curriculum that you need in dental school, teach baby dentists that are just graduating, how to do certain things, as far as taking care of additional items other than oral health, but diabetes, if there's any blood pressure concern, as before we administer local anesthetic, we got to take blood pressure. So are we able to address that immediately? And then also, again, vaccinations, I think would be very important because, sometimes most people do not have both a dentist and a physician or a PA or anybody like that to go to, consistently. There are some gaps there. So if we could close that gap with additional training in dental school, I think that would be good. CE was thrown out there too. I may not be popular suggesting this, but in Texas, we require 12 hours of continuing education. Well, do we need to incorporate additional medical training, where we check off that we did 3 hours beyond just normal dental training? I think that is a possibility. Those are just some thoughts and suggestions to put out there. But yeah, there's definitely a need to try to cross over more than what we're doing now.
Great. And Ms. Holland, what do you say about additional training that's needed?
Yeah, so I kind of have two sort of separate answers to that. First, I think that we have also an opportunity, particularly with the students, to introduce some community perspectives and make sure that the students have an opportunity to hear from members of the community that they're going to be serving. Since at its heart, healthcare is an equity issue and needs to be approached with those lenses. You know, whether we're talking about veterans or the Indigenous community or Indigenous community members who are veterans, you know, or whatever that looks like. I think that there is an opportunity for us to equip our practitioners to really hear from the community and understand that while they might be learning a particular trade when it comes to medicine or dentistry, they're going to be treating somebody who's going to be a sum of multiple issues, be they health, social determinant, environmental, personal, and all those things. So I think the more we can introduce that component in education, I think the better our healthcare outcomes will be, because the practitioners will better understand that. And then flipping that a little bit, I also think we have an opportunity, and this is outside of the schools, to work with our providers on not just the education that they need. I mean, it's really important that they know how to apply fluoride varnish. It's really important that they know how to do the vaccinations and have all of those skills. I think it's equally important that they understand how to introduce those to the practices that they're working in. And I know in Virginia, and Catalyst is not alone in this, we work with clinics to establish some aim statements and really figure out how best to become better integrated, recognizing that co-location is not integration. It can certainly help make it easier, but it is not integration. And so we've created here, and again, I'm sure that there are different examples across the nation, a continuum that takes what we see as the 8 most important factors of integration and helps clinics understand where they are on that continuum, so that they can figure out not just what skills they need, but also what operational changes they need to make to be able to be more integrated as well, so that it isn't just equipping a practitioner with a skill, but also equipping the practitioner with the resources surrounding them so that they can treat the patient more holistically.
Good. Thank you to all 3 of you for that. Okay, so the final question is for all the participants listening in. They want to know what's next. So what are some specific things audience members for this panel session could do, or action steps that they could take to improve integrated and interprofessional care delivery for veterans specifically? So let's start with you again, Ms. Holland.
Yeah, so Virginia Health Catalyst is at its heart of policy change and advocacy organization. So I think I am by natural tendency going to veer to what kind of long-term system policy changes do we need to make to ensure that it is easier for patients to access comprehensive healthcare that's integrated and practitioners to provide it. We could do that at the veteran level and really thinking about the VA itself and some of the protocols there, but also recognizing that veterans are receiving care everywhere. And so by improving the healthcare system writ large, we are making it more accessible to veterans and really recognizing their needs as well. And so I think that as we look at policies that change payment structures so that we are incentivizing preventive care, that we are incentivizing value, and really starting to recognize that healthcare at its core should be able to focus on prevention and stopping things before they start. And the best way to do that is to be ensuring that, again, you have no wrong door. So really thinking about what some of those policy changes might be it at the state level, ensuring that Medicaid is covering all of the healthcare services that an individual needs to be healthy. So like in Virginia, we just added dental benefit, and I know several other states are getting ready to do that as well for their Medicaid members. At the federal level, we were kind of excitedly for a minute talking about a dental benefit in Medicare and thinking what that might do for our citizens that are really needing coverage across the lifespan, and still certainly an opportunity to be able to do that through some administrative changes. And I think we can also look at some smaller P regulations in terms of we talked about accreditation or thinking about licensure, and how do we make sure that we're baking in the end that we have in mind.
Great. Dr. Jakes, how about you? What are some action steps people can take from this panel?
Yeah, I mean, essentially just breaking down silos, just giving the ability to, again, work together. I know I keep saying it, but just working together within the medical dental community to be able to find out what other resources are for our veterans. I mean, specifically, there are some programs out there. I know in Texas, they have the Texas Mission of Mercy. Well, sometimes they focus on for just veterans. They do that. And, who knows about these different projects out there? I think it's good to be able to spread the word, but truthfully, if we can try to create additional, taxpayer dollars to help out our veterans for programs, I think, that would be a wonderful thing too. But yeah, essentially just breaking down those silos, I think would be extremely important.
Thank you. And last but not least, Dr. Silk, what are some things people can take home and do based on today's panel?
Yeah, I'm always someone who goes to a conference and then it's like, okay, but what am I actually going to do? So I think it would be great if people went and really were trying to spread the word about the role for the medical side of things. So pushing out Smiles for Life some more. But I like the fact that both of the other speakers here have brought up the idea of accreditation. So you sort of have carrots and sticks, right? Incentives and regulations. I guess on the one that kind of crosses both is a lot of medical providers have to do QI projects as part of their board certification. So I've done a number of oral health things in my office, and you can keep these super simple. So if someone was to say, well, how many veterans do I have in my practice? And then they were to go about trying to engage every veteran that comes in to get a dental appointment and to take care of their teeth, maybe give them a handout, walk them out to the front, make sure it's a warm handoff to making a call to the dentist. That would be a start. Every primary care office in the US, doing these little quality improvement projects that they have to do anyway, could be a start. I think the other thing I would say, and I think Ms. Holland was getting at this in terms of like, who are the other support members? Who are the other team members? The care that I provide is in homeless health and those who are housing insecure. So unfortunately, I do see a lot of veterans in that work. And I'm constantly working with community health workers and social workers and pharmacists. And those are all people that could play a role in engaging people around their mouths. When we've worked with local community health workers to ask and then know the resources and make those referrals, we have definitely seen an uptick in people caring for their teeth. Again, Smiles for Life has a module for community health workers, but there's other ways to sort of engage folks around that. So those would be some lessons I would suggest.
Well, that concludes our panel today. So I'd like to thank our three panelists, Dr. Hugh Silk, Ms. Sarah Holland, and Dr. Michael Jakes. Thank you for raising the issue of medical dental integration. So with that, we will go ahead and end. Thank you.
I have a few housekeeping things before we close, if I could. I know some folks are already exiting, but if you need the CEU code for today, for this session, it's MEDDENT 215 VET. And day 2 tomorrow, we'll find us again here, same time, same channel. Our focus for tomorrow will be on improving quality of care for veterans. Want to say another thank you to our partners and sponsors, the CareQuest Institute for Oral Health, the American Dental Association, Patterson Dental, Aspen Dental, and Delta Dental of Iowa. So make sure to visit their exhibit booths if you haven't already. One final shout out to our featured charitable organizations for the event, Minority Veterans of America and Fisher House Foundation. Please support them as well by visiting their booths and websites and let others know about the important work they are doing for veterans. And with that, thanks again, Rear Admiral Ricks, our panel, and I hope you all have a great rest of your day and look forward to seeing everyone tomorrow. Oh, code one more time. Coming at you. It's MEDDENT, so MEDDENT 215 VET.